So thank you very much, VitaFlow, for inviting me to speak, and thank you to my one patient. I've got 2 pregnancies to report on her, so a bit of a contrast from yours, Diane. So I've managed my one OTC deficiency patient through 2 pregnancies successfully, and that's what I'm going to talk about. So as most people in the room are familiar with, the OTC deficiency is a deficiency of an enzyme in the mitochondria in the liver, and it's the most common of the urea cycle disorders. So, and I think that the incidence is something like 1 in 60,000, 1 in 70,000, depending on what you read. So the build-up of ammonia is what happens if this is untreated. So the unusual thing about OTC deficiency is the genetics aspect, in particular pertinent if you're trying to get pregnant and you're concerned about the outcome for your offspring. It's X-linked. Also that means what does that mean for women with this? And we know that the build-up of ammonia can have really devastating neurological consequences in, say, young boys. So paediatric colleagues will know much more about that than me. However, there are case reports in the literature of women who have been diagnosed on a post-mortem basis, and that's following pregnancies and deliveries. So actually there's quite a high level of concern for these patients. So just very briefly then, because you all know this, I think, treatment of OTC deficiency, the main aims are achieving normal growth and development in childhood, and women being carrier manifests are often not diagnosed in childhood. But then once they've been diagnosed and then going into adulthood, making sure that their nutrition is complete for their sort of maintenance needs, if you like, and then preventing any hyperammonemia, any metabolic crises, and providing a good sort of quality of life and preventing, admissions and so on. So the principles of the treatment, and I've put here low protein diet. I don't really mean super low, I mean moderate low protein, so a safe low protein, a safe protein intake as defined by WHO in 2007. And then also alluding to the literature, there's a couple of really great surveys of practice that were done about dietetic practice in UCD in around 2012-2013, Adam et al. Surveying UK practice and then also European practice. So we know that some of us do use essential amino acids regularly in these patients, some of us don't. And obviously we would make sure that the patients are under some sort of nutritional surveillance and have micronutrient supplementation. They also, it's important to have nitrogen scavenging drugs, so benzoates, butyrates, and arginine. And the crucial thing is preventing those admissions and decompensations by use of an emergency regimen, or really ensuring that we minimise or mitigate the effects of catabolism, so regular carbohydrates. And in some of the paediatric patients, and I think considered for adults as well, then liver transplantation might be indicated. So just going on to my patient then, she's now 36. She's got this mutation which is associated with actually not a great deal of enzyme activity. So she's got a history of decompensations, ICU admissions with encephalopathy, and she's been regularly attending through A&E from 15 to 33, at which stage her first pregnancy was occurring. So she had 4 admissions since the age of 33, which is what I'll touch on. She's high achieving educationally, and she's now the mother of 2 children. So just briefly, her medical management is as you would expect. So she has these nitrogen scavengers, she has B12 IM, she has micronutrients, and she has this moderate protein restriction. She's not consistently compliant, but, pretty good. She doesn't use the emergency regimen perhaps as often as maybe she should. And dietary management-wise, so I'm just going to tell you the bare bones. When I started really getting involved with her, I've known her for the last 10 years, she was in the middle of a taught doctorate and very sort of stressed out, and her logistics, she was living away from her husband, and I wasn't really, I was concerned about her weight, so we spent a lot of time getting her weight further up into the normal range. I appreciate 19.5 is within the normal range. And she has a history of B12 anemia. Sometimes she didn't comply with her micronutrients. Sometimes she didn't comply with the nitrogen scavengers. And as I say, not always with the emergency regimen in time. So 2010, she is married, she's thinking about pregnancy and a family, and she decides to go for genetic counselling because of the inheritance pattern of this disorder, and also it can be quite catastrophic, I think. So I'm mentioning all of this because it required quite a lot of administration to get funding for pre-implantation diagnosis. So there's a really big journey that this family, this couple have been on. And the other thing is as well, it first alerted me to what pregnancy was going to be like, because she had a couple of obs and gynae procedures and ended up having to stay in overnight just for with hyperammonia after just quite a small procedure. So I thought, yikes, pregnancy could be quite challenging. So the emotional investment and the emotional journey was considerable. She had 2 attempts at IVF with implantation, which didn't work, and she'd had the genetic diagnosis of the fetus, or the embryo, should I say. Then she had a natural conception of an affected male and had a termination. That was really quite upsetting, clearly. Then she had a natural pregnancy. On the fecal DNA tests, then her fetus with a daughter, she then declined any further prenatal testing, because the worst that could happen is she would give birth to a carrier manifest, somebody like her, hopefully, or perhaps with less ICU admissions. She was due to do the DNA diagnosis or genetic diagnosis on the cord blood. So what I'd already done at this stage was optimise her nutrition prior to conception. She'd swapped to a pregnancy micronutrients. So she was going to have that. She was having the deluxe version with the 200 milligrams of DHA and with the 400 micrograms of folic acid. And then she became pregnant, and she had a much more intensive relationship with me on the phone or on email, demanding to know what she'd been eating all the time, because she'd been quite relaxed about the moderate protein restriction. She didn't really have a concept of what foods were high protein and what portion sizes, etc. So we started this intensive monitoring. We encouraged the emergency regimen, reiterated standard advice, but by 8 weeks I started to sort of think, I think I'll just put the pressure on. So we instigated more regular carbohydrates, the essential amino acid. I've got a question mark there because I didn't realise initially that this comes in 2 different sizes. So you might be having 8 grams of protein if you had the smallest of the petit filou, but you might have a larger one, which I soon discovered. She had lists of 200 calorie, 50-ish grams of carbohydrate snacks. She was to eat every 3 hours whilst she was awake. And I said, you must only sleep for 8 hours at a time. And we talked about, actually, she was going to have glucose polymer every single night at bedtime. I was a bit worried about her bedtime, actually. I was like, do you think you could stay up a bit later? She ended up getting an antiemetic from a GP, one that's safe in pregnancy, cyclizine, not safe in OTC deficiency, as it turns out. And we talked about fatigue management strategies. 3 weeks later, she's in ICU, and she's got a pneumonia of 300. She's encephalopathic, uncooperative, sedated, etc., etc., etc. And as most of the people in the room will know, you have to have a blow-by-blow dissection of what happened before the admission. And she'd been asleep for 14 hours, probably due to the cyclizine, because I looked it up in the BNF, and it turns out it has a slight sedative effect. So, warning everyone, probably think very carefully before using that in the future. She recovered from the ICU admission and went home on day 5. She'd had some ONS to sort of kickstart her oral intake after her sedation. Going into trimester 2, we gradually upped the protein amounts, bearing in mind that she'd never really had this level of protein intake scrutiny before. I had to teach her 6-gram protein exchanges, and by the end of the second trimester she was on 60 plus grams of protein, and actually both of us became quite heavily reliant on the glucose polymer, and it was really helpful for work. Her fecal anomaly scan at 20 weeks was normal. And by the 3rd trimester, we were building on that protein intake, but quite slowly, with lots and lots of ammonias being done. Well, quite a few ammonias being done, not as many as her metabolic team would like. And then at 32 weeks, she was on ad-lib protein. She stopped her essential amino acids, but then we got an amino acid profile back, which triggered us to restart them. She then thought actually she was a bit concerned about her weight gain, so she stopped the glucose polymer. However, at this stage, the fetus was growing very nicely. 24 weeks, we started growth scans, and all the interval growth scans after that were around the 50th centile for all abdominal, head circumference, femur length, and her fetal weight as well. So this is her weight, little dip, probably that was around the time of the ICU admission. I found out that she visited her granny in her nursing home and had her lay down on the nursing home's beds as well. So that's how tired she was, having a bed in a nursing home aged 34. So yeah, she gained weight very nicely, went up to about 70 kilos. And then, as Diane has talked about, you need to manage the catabolism of labour. So we had her booked in for inductions. We had all the IV dextrose, IV meds, IV everything stocked up. We had the plan written in about 20 places in the hospital and all over the patient's families, cars and everywhere. She is quite a busy woman. She's quite intelligent, but quite a busy person, so she could turn up anywhere without any paperwork. This was the peripartum dietetic management. So I was going to descale down her protein intake. And this took a lot of persuasion because it would involve low protein prescribable products. She'd never had them before. And I was very pleased about my sliding scale SOS 25 at this stage. And some of you saw this because I decided I needed to check it out with my colleagues. I thought if I wasn't at the hospital, because I'm part-time, if I wasn't at the hospital, that anybody could go and review the patient on my behalf using my amazing spreadsheet of snacks versus SOS 25. So this took quite a lot of persuasion to get her organised, but we did. And the plan afterwards was she would continue with this IV dextrose. We would titrate in the SOS 25, we would titrate in the snacks, and we would monitor the ammonia. We probably got a bit overexcited, and she had 7 ammonia tests in one day when I reviewed it. So we were aiming for 2,500 calories, and I'm reporting 2 different pregnancies sort of collapsed into one, but she was actually, I think she went home on day 8 on the first pregnancy, and then slightly later after that. And then afterwards, after giving birth, lots more ammonias, because we were really quite concerned about the involution of the uterus. The involution of the uterus is a massive collagen dump into the person's metabolic system. Pregnancy number 2. Well, apart from the ICU admission in the first pregnancy, we were really quite pleased how everything went. So we did the same thing, only minus the cyclazine. The patient still became hyperammonemic and ended up with an even higher ammonia. I'd used loads of glucose polymerized, really nagged her on the carbohydrates. There was no ICU. There's absolutely no identified triggers this time. No lying down in a nursing home. The rest of the pregnancy after this hyperammonemia spike, we just basically relied heavily on carbohydrates and SOS. And as you can see, look, they're just almost identical times. Pregnancy 1, pregnancy 2. So all I can say is that what I maybe didn't take into account is that she actually had a 2-year-old to look after at this stage. Just to cover the follow-up, she breastfed successfully and was supported to do this. We returned to a safe protein intake. I couldn't persuade her after giving birth to have more essential amino acids. I would have liked that. She did certainly take a lot more glucose polymer in the immediate few weeks after giving birth, because we were paranoid about that protein, the catabolism, the involution of the uterus and everything. And we did a stepped return to this safe protein intake as well. So I'm sure you are interested to know about the outcomes. Both babies were beautiful, as are all the metabolic babies, of course. The daughter, her firstborn, is a patient of Camille's and has OTC status, diagnosed postnatally on, the neonatal biochemistry is a bit unreliable, but on genetics. So she's a carrier manifest like her mummy. And pregnancy number 2, we knew that the son was unaffected, because as soon as it was known he was a boy, he was diagnosed prenatally. And we have continuing follow-up with mum. Again, never as many ammonia tests as we'd really like. What did we learn? Avoid catabolism at all costs if you can. Protein intake, it's quite tricky to know how quickly you can step it up, and then also by how much at a time. It needs to be practical for these patients. And then peripartum protein restriction, how long do you do that for, and how do you step it back up again? The use of the SOS, well, that was pretty easy. We went up to about 8 a day at one stage. And the amino acid supplements, she told me which one she liked best. It was the one in the blue box. And it was nice with Petit Filou. The breastfeeding and post-pregnancy weight loss actually did go as planned. My learning points were that all of our communication was clear and simple, both for her to fit in with her busy life and all across the rest of the healthcare professionals looking after her. And I had some incredibly useful clinical supervision, and both Sarah and Sarah are here, but Louise and Charlotte are not, but thank you to them. Those were some of the things I read. So there's the General Survey of Practice in Urocycle Disorders, and then there's some pregnancy papers as well, and then the general medical guidelines. But there are a few more cases out there.